discuss, I hope, an interesting topic, and that is the management of hypertension. While we'll be providing a lot of information for us healthcare professionals, we're really going to focus on increasing the time that patients are involved in the management and their care, and really bringing them to the center of the team. Next slide, please. Well, we're going to talk about hypertension. I put this slide up front and center because really what we're going to be talking about is change. And one of the Greek philosopher, Heraclitus, said, change is the only constant. And that is correct. If we're not changing, we're probably falling behind. Next slide. Well, what is the process for successful change if I'm going to ask all of us to really consider changing our practices and the way we manage hypertension? And also, I'm going to be asking our patients to change too, to increase their involvement. There was a gentleman by the name of Cotter in the 80s, et cetera, that really was the father of looking at industrial change, organizational change, and really it was about the auto industry, the US auto industry, where he noted that while still making lots of money, selling lots of cars, the change was happening. Imports were coming, et cetera, quality was improving. And he looked at how organizations change and came up with these 8 bullet points. But really, the one that's front and center and the number one bullet point is, for successful change, Cotter prepared and talked to us and demonstrated to us that we needed to establish a sense of urgency, the so-called burning platform. It can't change if we think everything's okay. And as we're going to see in the management of hypertension, things aren't okay. Next slide. Well, here's the sense of urgency again for hypertension. There's no question that cardiovascular disease is now the global #1 factor for morbidity mortality, including, of course, in the United States, and particularly in states such as mine, in South Carolina, the so-called stroke belt. Hypertension is the leading risk factor for cardiovascular disease, so it should be on the forefront of our management, et cetera. Unfortunately, that's not the case. Hypertension control rates globally, and that is using a blood pressure of less than 140/90, are dismal. They're approximately 20%. And as we're going to see, that's just not globally. That's in the United States and in our own states as well. This is despite safe, effective, and affordable pharmacologic treatment being available. So what do we need to do? Such as today, I think we need to start honest discussions regarding how our current practices have got us so far, but have not been successful in increasing the target and increasing our hypertension control rates. Thus, I'm asking all of us, patients included, to examine opportunities to increase the control rates of hypertension. And as you're going to see, this is a team sport. And the definition, we've heard this over and over again, of insanity is doing the same thing, again, over and over again, but expecting different results. Next slide. So what's the burning platform for us here in the United States, in our individual states? Well, we're in for a rude awakening. The N. Haynes report monitors blood pressure control rates continuously over the past 3-4 decades. And in our last 2 surveys, particularly the one in 2013 to 2014, before the COVID pandemic, hypertension control rates were increasing, albeit gradually, but they were still going up to approximately 54%. We all thought, okay, let's just keep doing the same thing, and gradually we're going to get to 70, 80, 90% control rates. Well, we were sadly mistaken. In the survey of 2017 to 2018, again, pre-COVID pandemic, for the first time in our tracking this data, we noticed that hypertension control rates significantly decreased to approximately 44%. And this is using a blood pressure of 140/90 or less as control. If we use the ACC-AHA criteria, which we're going to talk about this afternoon as well, of 130/80 or less, our hypertension control rates are now at only 19%. This would be fine if it was, or maybe okay if it was just a number, but it's not. It's outcomes. This reduction in hypertension control nationally also parallels the recent increase in cardiovascular disease-related morbidity and mortality. Thus, this is the platform that I like to submit to all of us right now for change and for us to really look inward and start a discussion of how in the world can we change what we're doing and also change to increase hypertension control. Next slide. Well, this just wasn't noticed by a few people. It was also noticed by our Surgeon General. Those numbers were so striking that our Surgeon General in 2020 published a call to action to address hypertension control rates. Now, remember, this is in the middle of the pandemic. Surely our Surgeon General was swamped with all other eminent and priorities, including obviously the COVID pandemic. But our agencies felt it was that significant to address this reduction in hypertension control that they issued this Surgeon General's call to action. And it had 3 goals. Number 1, make hypertension again a national priority. Number 2, ensure that the places where we all live, work, learn, and play support hypertension control. And that brings in the patient. And finally, to us healthcare professionals, we need to optimize patient care for hypertension control and develop strategies. And the very first strategy of the Surgeon General's report, Strategy A, is the call to advance the use of standardized treatment approaches and guidelines, recommended care, including having a small hypertension formulary and a pharmacologic treatment protocol. I put this in bold because we're going to be talking about this over the next 20 to 30 minutes, but we're also going to be talking about it as we as healthcare professionals to hopefully adopt, but more importantly, to bring the patient into as part of the team and also teach them the hypertension formulary, the hypertension protocol, and the steps so that they can follow their individualized care. Next slide. So what we're really talking about is a continuum of what we've already been doing, but getting better and better and better. In my lifetime, for the pharmacologic approach to treatment of hypertension, we've gone from no care. There was no evidence based in the 50s and early 60s that treating hypertension decreases outcomes. And in fact, even if there were, the pharmacologic armamentarium that we had at that time was small and dismal. However, things changed, and they changed rapidly. Pharmacologic agents and classes were obviously being developed. Step care then took hold, and step care was, let's start with one medication, a thiazide or thiazide-like diuretic for everybody as step 1, maximize the dose. If they still weren't controlled, add a second agent, maximize that dose, and so forth and so forth. That kind of took way to that one-size-fits-all approach of just one pharmacologic agent as step 1 for everybody to the next step, which was individualized care. And what that's offered us was we could start any one of 3 or 4 classes of antihypertensive medications at the time for that initial step. However, even this individualized care step still required a step care, a titration and dosing regimen where you start with one medication, maximize the dose, a second, maximize, a third, maximize, and so forth. What I'd like to propose today is all of us, healthcare professionals and patients, come together and really examine a population-based approach where we treat the population of hypertensive individuals, but then obviously we always treat the individual at hand. Next slide. Well, to improve hypertension control rates, we should acknowledge, well, what are the barriers? What is stopping us from increasing hypertension control to 80, 90% of our population when we're mired in the 40 percentile range at best? Well, there are patient barriers, there are healthcare provider barriers, and there are health system barriers. But for the rest of this session and today, let's center on the patient barriers and see how we can bring the patient in, address these barriers, hopefully improve these barriers, and then bring the patient on board as their own agent of increasing hypertension control with us. Next slide. Well, let's look at some of the individual patient-related barriers more specifically. And I'm sure we can think of many, many more that are not on this slide. However, I just took a quick shot at some of the major patient-related barriers. One is that, as we all know, and the patient also knows, is hypertension is an asymptomatic disease, so-called the silent killer. There's not a pain, there's not a warning, there's etc. And obviously that prohibits and is a barrier to the patient then obviously at recognizing that hypertension is serious, etc. And we have to go out of our way, obviously, then to bring the patient in and educate the patient that yes, it's an asymptomatic disease, but it's a deadly disease if left untreated. We'll talk about that. Obviously, the patient can have information, insufficient education, so-called know your numbers. I truly believe the patient should know what the blood pressure threshold is to start pharmacologic treatment and why, and then what is the target for that individual patient or that population that we're treating. Giving them that information emboldens them and again, makes them part of the team where they want to achieve success as much as we do. Also, oftentimes we hear from patients that lifestyle management is difficult. Of course it is. So let's talk about that. Let's acknowledge that. But let's still see how, if we even pursue modest lifestyle management, we can rapidly lower blood pressure in conjunction with pharmacologic treatment and hopefully then increase our hypertension control rates. Well, we all know that there's poor adherence to treatment, and there's many, many reasons for lack of adherence. So let's address that with our individual patients. Patients fear side effects. They hear rumors, there's the internet, etc. There's all this doom and gloom. But let's remind us, as well as them, that our pharmacologic anti-hypertensive medications are relatively side effect free. And if we use them appropriately, they're extraordinarily well tolerated as classes of medications. And obviously there's cost of medications, which needs to be addressed. And again, I'm sure all of us could add to this list. Next slide. Well, I don't know if this is your patient, but it clearly could be one of mine. Here's the healthcare professional and patient in the exam room. And the professional, the physician says, well, your blood pressure is extremely high, Bob. And then Bob says, well, whatever, doc, I take everything with a grain of salt. And I think that sums everything up regarding how now do we approach this patient, who obviously we're talking about sodium, et cetera, and being one of the lifestyle modifications that can improve our blood pressure reduction and control rates. But if you take a real close look at Bob, our patient, you also notice central obesity. So not only does he have hypertension, but he also may be working his way or already have diabetes, hyperlipidemia, et cetera, so-called metabolic syndrome, all obvious additive and synergistic cardiovascular risk factors. Next slide. Well, let's start talking about some of those patient-related barriers that we just outlined and listed. Number one, hypertension is an asymptomatic disease, the silent killer. Absolutely. So how are we going to address this with our individual patients? Next slide. Well, I would submit that we show them the data, that yes, it's an asymptomatic disease, but we instill upon them, of course, that cardiovascular disease is the #1 cause of morbidity and mortality in our country, in our states, in our locale. And here is the prevalence of cardiovascular disease by age and gender. It's gender neutral. It affects males and females, obviously, equally at different times of our aging. But also that if we live long enough, that 70, 80, 90% of us are going to meet cardiovascular disease at one point in one way or another. And also then remind them that hypertension is the major risk factor for this disease. Next slide. Also, we have to be honest and recognize that there are racial disparities between cardiovascular disease onset. This is just an example of myocardial infarction, for instance, by age, gender, and race. Unfortunately, the prevalence of myocardial infarction goes up in everybody at all ages, and in this slide, white versus black races. However, that the black, obviously our black patients, be it men or women, are much more at risk for myocardial infarction. And as we're going to see, they're at much more risk for increasing prevalence of hypertension. Next slide. We also have to remind them, like Bob in that cartoon, that hypertension is one risk factor. It's the risk factor that we're going to discuss today, but it lives with all other risk factors. And you know these as well as I, but I submit that we share these risk factors with our patients. Next slide. And also we share why, that although hypertension, that number is asymptomatic today, it's not going to be asymptomatic tomorrow. And obviously teach them and discuss the target organs of the hypertensive process. We all know these target organs inside and out. However, let's remind our patients that this is really what we're trying to prevent. We are lowering the number as a surrogate to preventing target organ damage from hypertension, and devastating target organ damage, as we all know. Next slide. I think this is an important concept to also talk to our patients about. This is an old study, but it's incredibly important. It was a study by a pathologist, Dr. Pereira, I believe from Columbia School of Medicine in New York. And he was a pathologist and he did autopsies, but he also noted things in the chart. This was published in 1955. So Dr. Pereira presumably had to start this study 20 to 30 years prior to 1955. And what he noted was that even then, the age of onset of hypertension was 32 years of age. That's all. These were young individuals. These were complications in 500 consecutive untreated hypertensive patients that Dr. Pereira meticulously examined, of course, unfortunately, on the autopsy table. The mean age of survival of this 500 individual cohort was 20 years. So in 1955, the mortality of hypertension was with cancer. But more importantly, and for us to talk to our patients about, is once a target organ of the hypertensive process was affected, whether it be cardiac, cerebral, brain, renal, or hypertension acceleration, the mean onset of survival was dramatically reduced, anywhere from 1 to 8 years. I think this is important information to share with the patient, because while we want to obviously make sure that we're talking to them about lowering their number, lowering their blood pressure to prevent the complications, once a complication ensues, the mean age of survival is dramatically decreased. So yes, it's an asymptomatic disease, but it's a devastating disease that is preventable. Next slide. Let's talk about other barriers to blood pressure. You know, that is obviously patient related. We mentioned know your numbers and targets. I think most of us have gone through our cholesterol treatment programs, and there was if I remember right, a campaign, if you will, know your number, know your cholesterol level, etc. I believe that we should be teaching our patients their numbers as well. In other words, the number, what their blood pressure is. And of course, they could be monitoring this, and we're going to be talking about this at home as well, out of office. However, also teach them the blood pressure threshold that our evidence demonstrates we should initiate pharmacologic treatment in conjunction with lifestyle modification. But we need to go beyond that. We also need to, from the moment we make that decision, let's talk to our patients about the target that we want to achieve and why. And the why is because there's evidence-based medicine that reaching that target dramatically decreases the target organ damage we discussed, and we can show them some numbers, as we'll talk about. We must always tell them, always, 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 that lowering blood pressure has proven benefits. It's evidence-based. We know it works, so let's do it. And more importantly, we're also recognizing as not only is it important to achieve the hypertension control, whatever that target is in that individual patient, but The time that it takes, the rapidity that we achieve that control matters. The faster we achieve that control, the better the outcomes. And also, once we achieve control, we cannot rest on our laurels. We as the professional and the patient as well. The time that you're below the target, once target has been achieved, also matters. So we always have to be diligent. I think this education and having this discussion with the patient is important. And I'm hoping it will make a difference. Next slide. Well, here's some of the data that we can share with the patients. We know this data, but let's share it. Let's disseminate it. This is the ACC-AHA classification of hypertension. It's pretty straightforward. We can share this with them. They should know these numbers. They should know that the diagnosis or definition of hypertension for these guidelines is 130 to 139 over 80 to 89, and we would discuss treatment targets or even treatment initiation at this stage. And stage 2 is 140 over 90, at which all of us would agree pharmacologic treatment is warranted. Next slide. There's also newer guidelines we can share with them, and that are very, very consistent with the ACC-AHA guidelines. I was very blessed to be part of the WHO guideline committee most recently that published the recent WHO guidelines in 2022 in hypertension. In the general population, and we need to share this information with our patients, at any age, initiate pharmacologic treatment at greater than 140 over 90. So there's our blood pressure threshold with a target of less than 140 over 90. If you want to have also discuss a target of less than 130 over 80 per the ACC-AHA guidelines, absolutely. However, there are other individuals that have existing cardiovascular disease, already have diabetes or chronic kidney disease or both, or are at high cardiovascular risk according to cardiovascular risk calculation. And the WHO guidelines, again, congruent with the ACC-AHA guidelines, recommends initiate pharmacologic treatment at a systolic blood pressure of between 130 to 139 with a target of less than 130. So our individual patients should know these blood pressure thresholds, the number, if you will, and the target we're trying to achieve. That brings them as part of the team. It should not be a secret that we only keep to ourselves. Next slide. And here's the benefits that we can share with them, that what we're trying to prevent absolutely is preventable. These are data from older studies where our threshold, our targets were actually higher than recommended today. But even with those modest targets, stroke reduction was approximately 40% by lowering the number. Myocardial infarction risk, which we've already demonstrated the prevalence, was 25%. And heart failure, 50% or greater. These percentile reductions are even lower now with our lower blood pressure targets, if you will. The next slide. So another barrier that we hear from our patients is, well, lifestyle management is difficult. Well, the first thing to do is agree with them. Say, absolutely it is. It's not easy. It's not easy to change habits that we've had for whatever number of years they walk into our offices. However, it's possible. And even modest changes in lifestyle management produces results. Next slide. I like to share this data with our patients, and you can focus it on one of the modifications at a time, et cetera, and not give all of this data to the patients all at once. However, even modest reductions or changes in lifestyle modification produce dramatic results in combination with our pharmacologic treatment. Weight reduction of modest amount decreases blood pressure substantially, as does adopting a DASH or Mediterranean diet, reducing and even moderating sodium intake, increasing physical activity, even moderately. Look at the blood pressure reductions that are achieved and moderating alcohol consumption. And this is encouraging because even little modifications can make a big difference. in any or all of these lifestyle modifications that pertain to our individual patient. And showing this data, I think, gives them not only hope, but also expectations. Next slide. So going on to further to patient more or differing patient-related barriers, if you will, I also often hear that, well, from our patient, well, out-of-office home blood pressure measurements are cumbersome. Yes. However, we're recommended they take their blood pressures at home for all kinds of reasons, as you know. However, with our new automated, oscillometric, and more importantly, validated devices, it is getting much easier to take blood pressures. However, we still want them to take it appropriately. But we also have to remind them that our home blood pressures may differ from our office blood pressures and the reasons that we're asking them to take their blood pressure, because it'll make a difference. It'll make a difference in the thresholds and the targets that we are recommending, as well as obviously outcomes if we can achieve blood pressure reduction in both milieus. We'll address poor adherence to treatment and how can we improve adherence. Address their fear of side effects of medications to remind them that our newer antihypertensive medications in the doses that we're going to use and when we're going to use them in combination, reduce the fear of side effects dramatically to almost zero. Obviously, it's never absolutely zero. And of course, we can address the cost of medications with generic medications, et cetera. Next slide. I'd like to spend the rest of our time together with this concept. And the concept is, together with our patients, to moving towards a population-based primary care approach to reducing blood pressure and increasing hypertension control rates. It's a critical strategy that works. It addresses some of the other barriers, some of the barriers that are on our shoulders, if you will, such as clinical or therapeutic inertia. And one of the keys to a population-based approach is using a simple, straightforward, and standardized treatment protocol that we are going to share with our patient. And this approach can be adopted at any level, from an individual practice to a system, to a state, to a country, to a region, and even in my hopes, whatever it would be at some point globally. But there's some principles, again, that we can share with our patient. Number one, the algorithm or treatment approach must be primary care based. It's for the patient that's the rule, not the exception. There's always going to be patient exceptions, and we can deal with those individually. However, 80 to 85% of our hypertension patients, if you will, are absolutely applicable to a population-based treatment algorithm approach. The treatment algorithm needs to be simple and have very few titration steps, and we will share these steps with our patient. And one of the things I want the patient to know is that one of the current recommendations that works is we should start with 2 antihypertensive medications once we diagnose the hypertension, decide the threshold to initiate treatment has been reached, and we agree that pharmacologic treatment is now indicated. Let me say that again. Once that is met, we start with 2 antihypertensive medications that are complementary to one another upon the initial diagnosis. And we start with them at half maximal doses of each agent. And if even better, if they come in a fixed dose or a single pill combination together, that's even better. And clearly, and evidence-based practice now clearly demonstrates markedly improves adherence. Next slide. So we can share these with the patient. There's many advantages of initial combination pharmacologic treatment, either as 2 separate pills or together when you use complementary agents. And many of these address the patient-related barriers, as well as address some of our related barriers as well. Clearly, we could tell the patient that almost all patients with hypertension, now that we want to achieve lower blood pressure target levels, will need 2 or more medications. So why not start with 2 at the get-go? We also can tell them that and remind us that there's additive or synergistic effect, blood pressure reduction, when we use 2 agents in combination. And when we do, We use lower doses of each, which reduces side effects to almost minimal side effects. It's simplified and it improves our patients' adherence, gives them a better shot at taking their medications. It helps us reduce clinical inertia. And this is important to our patients, and especially in a population-based approach. When complementary drug classes are chosen, we lower the blood pressure equally in all diverse demographic groups. And there may even be benefits to society, our systems, et cetera, that eventually and ultimately it will lower total healthcare costs, affording fewer office visits because control has been reached and blood pressure control has been reached more rapidly. Next slide. And here are some of the characteristics that we can share of these two classes together. I won't belabor them because many of them address the same advantages that we just discussed. Next slide. So here are our three classes that obviously we can share with our patients that are recommended in all guidelines now as upon the initial diagnosis of hypertension. Either the thiazide or thiazide-like diuretics. Patients know these as fluid pills. Our ACE inhibitors or our ARBs, angiotensin receptor blockers, we know them as renin-angiotensin system inhibitors, and our calcium channel antagonists. So if we're going to start with two medications, we can tailor two of these medications to the patient and or decide on a combination for our population of either of these two. So you could do the permutation and combinations as well as I. They're not very many. Next slide. Many times our patients will also ask me, or we'll even question ourselves, well, what about beta blockers? When do we use beta blockers in the management of hypertension? And we do not use them as in the initial step. In fact, they are now reserved for fourth, fifth, or sixth line therapy for blood pressure reduction. But of course, if there's other compelling interests or indications for beta blockade, of course, we use them in conjunction with our other classes that are noted on this slide. Next slide. Well, I was asked a few years ago to put together a large group, a global group, if you will, to decide which two agents should we start. And again, I share this with our patients. Number one, we came up with as a group, because of some evidence-based medicine, predominantly the COMPLISH trial, that the combination of an angiotensin receptor blocker and calcium channel blocker should be could be our first preferred step. If that can't be achieved for various reasons, an ACE inhibitor and a calcium channel blocker was second. And if that can't be achieved, then start with an ARB and a thiazide, and or an ACE and a thiazide or thiazide-like diuretic. One combination we did not recommend initially was a calcium channel blocker and a diuretic. So we really only have four choices in combinations if you want to follow this recommendation. The reason for the ARB over the ACE as the renin-angiotensin system inhibitor was side effect profile and adverse effects, as we're going to see. Next slide. And I talk about this with our patients to bring them in as part of the team because, again, side effect profile is important to our patients. And there's a lot of misinformation out there. ACE inhibitors are associated with a much greater incidence, if you will, of cough and angioedema. And there's racial disparity regarding cough and angioedema, where our Black or Hispanic population, our older population and women, et cetera, have heightened risk. Cough and angioedema is not increased with angiotensin receptor blockers, and thus that was the recommendation, if we can, to prefer an angiotensin receptor blocker with a calcium channel blocker, and as you're going to see, that calcium channel blocker is amlodipine. So this is important to talk to the patient about from the very, very beginning, because this rationale, this approach, markedly reduces side effect profile and tolerability of the agents and removes one of the barriers that's very, very common to achieving patient-related hypertension control. Next slide. So again, these were the three preferred classes, an ARB versus a calcium channel blocker. followed by an ACE, calcium channel blocker, ARB, diuretic, ACE diuretic, and here's some example agents for us as the provider. But one thing they all have in common is they're all long-acting and they're all once a day. Next slide. Well, this is our clinic. So everybody says, well, it's Dr. Petty, you can talk about this stuff. Do you really do it? And the answer is yes. Our clinic here at the University of South Carolina and Prisma Health, our internal medicine primary care clinic, is a low-income, low socioeconomic targeted population. And this is our data. This is our demographics. Number one, they're older. They are heavily weighted towards female. And obviously, about approximately 80% of our clinic population is Black. And you can see the payer sources parallel the socioeconomic status of our clinic. Most are no pay and or Medicaid. And obviously, if they're older, they have Medicare. Next slide. Well, this is our algorithm. This is our protocol, and it is plastered in a huge, huge poster in our clinic, on our clinic wall. And we actually give this algorithm to our patients because it demonstrates what the steps are and what the steps are likely to be and involves them in their care. Because of affordability and obviously cost, our protocol starts with losartan at a half maximal dose, 50 milligrams, and amlodipine at a half maximal dose of 5 milligrams upon the initial diagnosis of hypertension, whatever that threshold you want to set. We would prefer a longer acting ARB, however, because of cost and it alleviates that barrier to their hypertension treatment and brings the patient into involvement. We've chosen losartan versus amlodipine. If one wants to use a longer acting ARB, absolutely, that would even be better. If the patient's not controlled within 1 month, then we double the dose of each to 100 milligrams and 10, which is the maximal dose. Again, following the guidelines that we already developed for the protocol. If they're still not controlled, we add a thiazide diuretic, hydrochlorothiazide at 25 milligrams. 1 month later, if they're still not controlled, we double it to 50 milligrams. And as you can see, within 4 months, you're on maximal doses of the 3 recommended classes of antihypertensive medications, and you'll likely achieve blood pressure control in 80 to 85% of your population. If they have resistant hypertension, of course, you can refer to a subspecialist and or add spironolactone to your protocol at 25 milligrams up to 50 milligrams, et cetera, as you feel comfortable with. But this is sort of like practicing what we preach. Next slide. And our recent WHO pharmacologic treatment guidelines for adults supports this. And this is recommendation, I believe, 6 of the 8 WHO recommendations. And they recommend for adults with hypertension requiring pharmacologic treatment, start preferably with a fixed dose combination or single pill combination if available, but choose 2 antihypertensive medications upon the initial diagnosis from these 3 classes that we've already outlined. And our AHA-ACC guidelines also support the use of 2 medications upon the initial diagnosis. Next slide. So where are we and how can we put all of this together? Again, putting the patient at the center. Well, here are some conclusions. And again, I hope we can all come up with different ones and or change or modify at our leisure. Number 1, the urgency. Go back to the burning platform. Hypertension control rates are dismal, and it's time for dramatic change. Hypertension management is a team-based sport. This isn't tennis or golf. This is football or soccer or basketball with the patient at the center. We also need to understand the patient's perspective. We obviously, it's easy to think of our perspective. However, let's turn the tables, if you will, and look at it from the patient's side. What are our individual patients' barriers to care and to control? And some may have all of the ones we discussed, or just a few, or different ones. But let's put that into our practice, as we almost certainly already do. We may not just think about it or be cognizant as much as we should be or could be. Address the issue of hypertension right up front as the silent killer. However, it's a deadly killer. Communicate the blood pressure treatment threshold and goal initially with the patient, and that the faster achieved in terms of blood pressure control, the better the outcomes. So it's not only doing it, it's the rapidity of which we can do it. And again, that algorithm contributes to that. Explain that lifestyle modification is doable, but it can be incremental. And it doesn't have to be all of them. Just start with something and move forward, and even modest improvements in lifestyle modification in those differing domains dramatically improves our blood pressure reduction with pharmacologic agents, and that gives the patient incentive and hope. Next slide. And finally, make sure that the patient knows the treatment plan. Give that plan to the patient, and that patient then can follow the plan and know when they come back for their next visit, if their blood pressure is still elevated, they're going to go to the next step, and they already know what that step is. Use a simplified, straightforward algorithm or protocol that uses 2 complementary medications upon the initial diagnosis of hypertension. That gets at the rapidity question. Share the algorithm, as I've already mentioned on several occasions, with the patient. You really know that you've succeeded when the patient tells you what their next step is. They beat you to it. They know the blood pressure when it's taken at the beginning of their visit. And if it's greater than whatever you discussed as the target, they already know the next step. They'll tell you the next step if we're all successful. Use fixed dose single pill combinations of two agents, or even 3 if available and affordable, and review the medications that are available and affordable, and that side effects with our agents when used in lower doses in complementary classes together is very infrequent, if at all. Next slide. Well, I want to thank you and the Southern Medical Association for having me, obviously, this afternoon, and getting us together. And we'll be happy, or I'll be happy, to entertain any questions or thoughts on your part.